Any questions or comments? Welcome. Dr. Girish, please.
Thanks, Dr. Manmohan. Excellent display of exquisite surgical techniques. Just about gamma knife, I was just wondering if you're making gamma knife for cavernous sinus surgeries, cavernous sinus lesions. How do you protect the third nerve or the sixth nerve which is back inside the sinus?
Yeah, exactly.
What are the radiation effects to the carotid artery? Do you find an increase in stroke or anything like that?
Exactly. So these our cranial nerves, they have the tolerance for, except the second nerve or its other connections, optic nerve, chiasm and the optic tracts, they have the radiation tolerance which is not high. So usually the upper limit is, we keep it around 8 to 10 gray is the maximum limit, but usually the safer side we keep it still lower to the 8 grays. So any radiation dose to the optic nerve should not cross 8 gray. So that tolerance is quite less, because majority of the lesions in the cavernous sinus of the elsewhere in the brain, we usually keep the radiation dose beyond 12 gray. So one single dose of 12 gray is a huge amount of radiation. For the youngster, I can tell you that a single fraction of 10 gray to the whole body in one go will 100% kill a person in 30 days. So that much is the lethality of this dose. A 10 gray whole body radiation in one go will kill everybody in 30 days. So it is a very toxic dose. So I am talking about the 12 gray radiation in single fraction, right? So that because the radial surgery works differently as compared to the conventional radiation therapy. What happens is that in conventional radiation therapy for the malignant lesions, it works on the principle of damaging the DNA of that growing tumor. So, because many of the radio-resistant tumors, like we know that meningiomas are practically radio-resistant tumors. Many other tumors are radio-resistant tumors. But it doesn't happen in cases with the gamma knife, because the dose is very high. What happens is that it causes the vascular damage, the microvasculature damage of the any tumor, because at that dose the microvascular vessels, which are actually abnormal vessels, right? These are not normal vessels. So these are abnormal vessels, their radiation tolerance is limited. So that as we increase the radiation dose, those vessels are damaged, those tumors, blood supply is gone, they shrink in size, they become dead. So this is usual principle. It doesn't work on the principle of damaging the genetic material. So as we increase the radiation dose, the more the damage. What happens is that the surrounding brain also sometimes, because no doubt the gamma knife and other sources of radiosurgery will have a very steep fall, so that the surrounding tissues are protected. But that is again on a limited extent. As ever the volume of the lesion increases in size, so radiation dose spillage to the normal structure is high. So now Dr. Grish's question is that why it doesn't damage the cranial nerves. The cranial nerve, usually the radiation tolerance is like third, sixth, because they are myelinated nerve fibers. So their radiation tolerance is up to 30 gray. So once we increase the dose beyond 30 grays, so they will have neuropathies. So usually we hardly ever see neuropathies in cases of cavernous sinus lesion, or per se we say that in vestibular schwannomas, where we give radiosurgery, I think, on everyday basis. So what happens is that the seventh nerve is never delineated, it's a part of the tumor per se. So seventh nerve neuropathies, I practically in last 20 years, I have seen just one case of which I remember that patient developed post-radiation seventh nerve palsy. So it is practically very rare. So for normal large vessel radiation problem, it is again the carotid artery is very big, and again its tolerance is beyond 30 gray. So up to 30 gray it is never a problem, because 24 gray is usual radiation dose for functional pituitary adenomas. Because the non-functional pituitary adenoma, we keep it around 12 to 14 gray, usually 12 gray, because if it is in close proximity to the visual pathways. But for functional adenomas, they will not respond to 12 gray of radiation. So they require almost the double the dose. Only then the prolactinomas, growth hormone adenomas and the Cushing's, they respond to 24 gray. So in 24K, we again will have a challenge to protect the visual pathways. The larger the tumor near to the visual pathways, sometimes we won't be able to deliver that. So that we always recommend that they should be debulked so that the residuals can be secondarily treated. So again, radiation is not a problem in normal vessels and the cranial nerves. So because of their radiation tolerance, they hardly ever a problem, because we never say save or shield large caliber arteries from the radiation field in stereotactic radiosurgery.
The question is regarding cavernous sinus surgeries. When there is a tumor approaching or complete encompassing a cavernous sinus, the venous bleeding, the sinus is probably occluded. One of the greatest concern about cavernous sinus surgery is the venous ooze. So I can understand that in a normal tumor surgery, but when you use cavernous sinus or open the cavernous sinus to extend your visualization, as you showed in some of the latter cases, to increase your approach towards the superior cerebellar or inferior glioma, is the venous ooze a concern in such?
Yeah, exactly. But the problem is that once you are exactly into that plane, because cavernous sinus lateral wall is very thin, flimsy wall. So what happens is that there are connection between the dura and some tributaries are there. So those tributaries sometimes bleed. So the easy way to connect them, then just don't try to coagulate or don't try to just compress them. Just with your tissue glue, you can just form them points. You can press it there and inject glue there. So instantaneously the venous bleeding goes away. So it is hardly a challenge. So, but you can continue if the venous bleeding is happening in your lateral wall cavernous sinus dissection. So probably it indicates that you are not in the right plane also. So if you are in the exactly correct plane, so venous bleeding happens, but they can be very easily manipulated with the help of your TCL glue. So not a difficult thing. I expect some queries from the youngsters.
Excuse me, sir.
Yeah.
I'm a neurologist, so I tried to follow much of what you said. It was an excellent talk. The thing that piqued my curiosity is that there were two cases where you sectioned the PCOM artery.
Yeah.
So in DSS, we routinely see that PCOM is the only thing that is supplying the PCA. So do you do a DSA or a CT angiogram prior to the case, or do you just visually judge whether it's a robust artery or not?
Yeah, exactly. So thing is that from the fetal origin of PCOM, so which is actually where you should not be having region, because you see directly the basilar bifurcation. You see the PCA coming out of them, and very thin PCOM is there. So then it becomes imperative that it is not a primary vessel supplying continuing as the P2 division. So because you are seeing it directly over there, so you can easily section that. The only challenge is that there are many times the multiple perforators which arise, which supplies the hypothalamus and the upper part of the brainstem. So you may have to judge that whether you want to section your PCOM near to the ICO or near to the posterior cerebral artery. So that is your judgment. So that, for example, the majority of the fibers, the perforators arising from the PCOM itself, they are more towards the ICA. Then you have to section it distally towards the PCOM, posterior cerebral artery. Or if vice versa is true, so there is paucity of perforator near to the ICA and more toward distally, so then you can section it there also. Because you see there, even if angiogram, so because on table it is visible that a very big trunks are actually coming out from the basilar bifurcation, one right, one left, the only very thin vessel is connecting, so you can easily section. So another thing is that many times we have seen that, so PCOM is very robust, not as thin as I have showed, it is very big, but it is again not a primary vessel supplying the posterior cerebral artery. So in that case, you just have to work around it. So either posteriorly or superiorly. So that is the situation. So it is an on-table sometime decision.
Sir, the meningioma case which you showed trigeminal neuralgia, you said that the nerve was not clearly visible, hence Kavanagh was that idea was not means what would they have, means if we would have irradiated that area with 90 gray
No.
along with the tumor?
So see, ultimately that, because again it becomes a volume. So radiosurgery is actually working around the what volume of the tissue you are irradiating. It is not the tumor, because the tumor will definitely have the volume around 1 to 2 cc. So maybe this tumor was fairly more than 2 cc of tumor. So 2 cc in practice we see that very small tumor, but actually it is a big volume at that point of time. So a 2 cc volume irradiating with 90 gray of radiation, it is a disaster in making. So it will fry off your brainstem because the radiation spillage is huge. Because we just use 4 millimeter collimeter. Collimeter is that through the holes from which actually the radiation comes and form a sphere of radiation at one typical point. So I think gamma knife, many of them you might not have seen how the gamma knife functions. Gamma knife is basically as multiple sources, 192 sources of perfection model which we currently using. The previous model, model B and model U used to have 201 sources. The current model has 192 cobalt 60 radioactive sources. They all are positioned in such a way that all 192 beams, they focus at one single point. So other way of describing it that we have a paper and a convex lens, and then we trying to burn out the paper with in the presence of the sun. We just go and up and down, we will burn the focus because we are focusing the sun's radiation into one point of the paper. I think everybody has done it. So it is the same function. So thing is that we use the only one collimeter which is around 3 to 4 millimeter anterior to the root entry zone of the fifth nerve. So in the cisternal segment, you have to identify the nerve and then around 90% isodose line, so that we have to select volume and then give it. It has a very small tiny point volume, and actually we are damaging or destroying the nerve. The flip side of now if you say that can we treat all cases of trigeminal neuralgia with the radiosurgery, my personal opinion, being a surgeon, being a radiosurgeon also, it's not a good idea because it is a destructive procedure. So we are actually damaging the fifth nerve completely. Problem is that it will cure the patient's pain temporarily, and usually the failure rate of radiosurgery in trigeminal neuralgia over 5 years is around 50 to 60%. So thing is that even those patients who have recovered, they will have facial hyposthesia. So initially they were troubled by pain, and later on they will keep on complaining that I have got a lot of hyposthesia, which is again not a good idea to have. So people, those who have hyposthesia, they are good responders. Anybody who has a good amount of hyposthesia, their pain will definitely go away. It means that they really responded well. Those people, those who have not developed that much of hyposthesia, it means that radiosurgery has not worked that well. They are likely to recur. Now, your question, we are damaging the nerve with 90 gray of radiation. So still many people, they are not lesioned. So myelinating nerve fibers, they have very huge radiation tolerance. Pardon?
Perforated damage in surgery.
Yes.
How aggressively, how much of a problem is that?
See, ultimately the thing is that for that you need a high magnification. Perforated damage happens when we have a very small corridor where manipulation area is less and our magnification and illumination is less. So that is why when we start damaging the perforated, because try to retract with the help of your suction, with the help of your bipolar, or maybe with the help of your retractor or your operating assistant. So somehow we have to do it. Many times the damage is not done physically, which I particularly feel. How the damage is done, many times we start coagulating the tumor in and around. So it is not the physical damage of the perforated, it is actually the thermal damage of the perforator. You have done a wonderful surgery, you have saved all the perforators. You post-operatively, patient might have done well for a few hours and then patient goes down. So we always, I am talking now in context with the vascular surgery, aneurysm surgery. So what happens is that we believe that patient probably has developed vasospasm. So I have now strong believer vasospasm doesn't happen so commonly. Many times we have done the thermal damage of the many of the perforators, which actually manifest maybe 24 to 36 hours later. So our coagulation in and around the perforator areas should be very, very minimum. You should be each catching them, dissecting them, not coagulated. See, many times the bleeding from these small tiny vessels, maybe ooze, can stop immediately or may take a little bit of while. You should not bother and you should not chase with your bipolar. So only thing is that dissect it off, wait for some time. So your bipolar usage, especially in craniopharyngioma surgeries. So I think you don't need bipolar coagulation in any of the craniopharyngioma surgeries, because once you are in a plane, many times the first time surgery, you can easily dissect it off from the all perforators. So if you start coagulating them, so the problems are more in those scenarios.
So what's your experience with captured cavernous fistulas? I mean, is there a surgical option or?
Surgical option is basically the last resort when anything is not working. So the only surgical option in that scenario is high flow bypass and just trap the ICA, neck and above. So if it is not working, so you need to have a high flow bypass in there. You don't have to go into the cavernous sinus because it will be a disaster.
Sir, I apologize if it's a very basic question. Your surgery, I mean, when you access the cavernous sinus, is basically about identifying the dural duplication.
Yeah.
So when you identify the dural duplication on the temporal side, my question is, do you drill down the superior aorta, the triangular bone to the periorbita in all cases, or do you just make it flush?
Yeah, exactly. I always drill, because then your groove, because there is always a groove there. So where the periorbita joins the temporal dura. So actually the dissection should start from there. So just drill out a bit of superior orbital fissure. You will see that groove. So you should have to drill from the anterior cleanout process till the foramen of rotundum. So we do, and then you will see the groove running there. So start dissection from there. You will never go wrong.
So you drill down only to see the groove, or you drill down to the periorbita and all?
No. I preserve the periorbita, and so that the periorbita is completely preserved, your temporal dura is preserved, and you see that groove. You will always see that groove, and your dissection practically starts from there. Thank you.